Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and we've got Dr. Sanjay Mohan, our toxicology expert, back on today as we are deep into winter. We're talking about carbon monoxide poisoning. I think this becomes much more of a concern at this period of time, although you can get it at other times of the year as well. The winter is where we really start to see this. And the speed of making this diagnosis, getting the management right, is so critically important. So Sanjay, we are going to dive deep into this topic. You ready?
As always, Swami, thanks for having me again. It's starting to get a little cold outside, wouldn't you say?
Oh, absolutely. And that's exactly why we're here discussing this topic. Here's the biggest crux, I think, of this particular diagnosis is actually figuring out the presentation. How are patients going to present where I have to be suspicious of carbon monoxide toxicity?
For patients with severe carboxyhemoglobin toxicity, is that they're going to present either dead in the field, dead on arrival, or in cardiac arrest. But that's going to be a vast minority. Most patients are going to present with mild toxicity. And unfortunately for us as ER physicians, that means a non-specific presentation. Non-specific presentation means headache, dizziness, nausea, vomiting, and generalized weakness. When you start to get to the more severe degree of toxicity, they may present with syncope, altered mental status, neurologic disturbance, myocardial ischemia, and cardiac arrest.
So a lot of the early symptoms are very nonspecific. And it's not just that they're nonspecific. They mimic other presentations. We're talking about November, December, January, February, when it's cold, when we see more carbon monoxide toxicity. And Sanjay, if I see headache, nausea, malaise, that's a common viral infection. Every time that is a common viral infection, it's influenza, it's RSV. We have these things running rampant. And of course, we've got COVID as well. There's all these different viruses that can cause all of these different symptoms. So how do I tease this apart from the patient with carbon monoxide toxicity? Because that's really important. The treatment here is going to be vastly different.
Dr. Goldfrank would often tell us, if you want to look at society's problems, look to the emergency department. Most carbon monoxide exposures occur unintentionally from indoor use of gas power generators, camp stoves, or faulty home heaters. A lot of social determinants of health, they have unstable housing and they have unstable sources of heat. So to answer your initial question, you have to have a high pretest probability. If they come in with viral symptoms and neurologic disturbance, viral symptoms, and you ask about their heating source, then I think you need to consider this diagnosis.
So these are the kind of questions that we want to be asking for our patients. And what it comes back to is I can't take every patient who comes in with a viral syndrome and get a carboxyhemoglobin level. If I could get those really, really quickly, or if I had some kind of a point of care, fast, rapid assessment, that would be great. But we don't always have those things. In fact, most of us don't have those things available. So what should be our trigger? What's the trigger to getting a blood gas and getting a carboxyhemoglobin level?
For sure. And I want to clarify, it's not specifically a blood gas, it's specifically a co-oximetry, which tells you the different types of hemoglobin, whether it's sulfhemoglobin, carboxyhemoglobin, or methemoglobin. I wish I could give you a good answer, but this is incredibly nuanced. And this really depends on pretest probability, as I mentioned before. I think if someone looks like they're having a viral illness in the context of multiple other family members, or their dog or their cat even seems a little unwell, I think that's a trigger to get it. And I know for most of us, especially as ER physicians, we kind of want to neglect the social history, but this is when the social history matters so much. Where do you live? What heating source do you have? If there's something of a red flag, you got to go pursue.
Yeah, I like to ask that question of who else is sick in the house. That can sometimes help, although we know these viruses also will travel around the house. The other questions that can be helpful, like you said, is are there pets in the house? Have the pets been acting kind of funny? That can be helpful. The other thing that I find to be useful is, do you feel better when you leave your house? Or do you feel better when you leave work, right? Because depending on what kind of job the person does, it could be a job exposure versus a home exposure. So that can be helpful because there's no viral syndrome where you're like, well, I feel terrible at home, but then I go to work and I feel great. Like that doesn't happen. So that might be that little bit of a tip off. So I will ask patients those kind of questions in the winter to try and be tipped off in this direction and say, I got to get a co-ox. Of all of the viral syndrome type patients that I see in the winter, it's just a small minority where I'm sending that blood test and getting that co-ox panel to make that diagnosis. Now, one of the other issues, we're all city dwellers. I mean, I live in the burbs, but in general, we are city dwellers. Our patients are city dwellers. And as city dwellers, we all have a little bit of carbon monoxide in our bloodstream at all times because, city living ain't that great for you. And this can be even a bit higher if the patient's a smoker. So if we are triggered and we get that co-ox panel, What carbon monoxide level makes us think this is poisoning as opposed to just kind of some background carbon monoxide exposure?
So whenever you send a coax with the context of you're looking for a carboxyhemoglobin, you should probably ask the following two questions. Where do you live and how much do you smoke? Because the fact of the matter is if you're a heavy smoker or you live in a heavily inner urban environment, your normal quote unquote carboxyhemoglobin levels may be 5, 10, or even 15%. So as with anything else in emergency medicine, clinical context matters.
I've got that co-oximetry done. I've got the level. I'm worried about toxicity. I'm worried that the patient's symptoms are being caused by that carboxyhemoglobin level. What are my initial steps in management?
The mainstay of treatment is supplemental oxygenation. Keep in mind the half-life of carboxyhemoglobin drops from 5 hours on room air to 1 hour when breathing 100% oxygen at normal atmospheric pressure. Specifically, that means via non-rebreather.
The other thing that we often talk about, and this is kind of on the boards, it is a standard answer that you kind of come back to, is hyperbarics. Hyperbarics is commonly discussed and hotly debated in carbon monoxide management. That hot debate is really within the toxicology realm. You have some toxicologists who are like, we're putting everyone in hyperbarics. You have some toxicologists like, I'm not sure that there's ever a role for hyperbarics. What should be our trigger to pursue hyperbaric treatment? And Sanjay, let's keep in mind, most of us don't have a hyperbaric chamber in our hospital. So that means I've got to transfer the patient somewhere. And that could be a couple of miles away. It could be a couple hundred miles away. It could be a long distance. So what should trigger us to say, I need hyperbarics for this patient?
There's never an easy answer for this, but as always, and I know you're going to hate me, Swami, call your local poison control center. The fact of the matter is these are complex, complicated patients that require expertise, and your local toxicologist, even your poison control center specialist, is going to help you out. I will say, from a neurologic disturbance standpoint, those patients should always be consulted on. Patients coming in with altered mental status, cerebellar dysfunction, or coma, seizure, or even syncope, you have to at least consider hyperbaric chambers. Purely from a numeric standpoint, a carboxyhemoglobin greater than 25% or a carboxyhemoglobin greater than 15% when pregnant generally warrants hyperbaric treatment.
All right, those two numbers are kind of important. So 25% in any patient, 15% in pregnancy. And then the other thing is that neurologic symptoms that the patient is presenting with. So syncope, any kind of altered mental status. At the absolute least, we are going to get our toxicologist on the phone. Honestly, if I have a suspicion of carbon monoxide, I get a coax and the number is elevated, I'm consulting tox on all of those patients. I think it's very helpful to do that. But one of the things that we kind of have to really be clear on is what the benefit of hyperbarics is. What is hyperbarics going to do for my patient? Because you said that the real central part of management is providing 100% FiO2, non-rebreather. It's going to reduce the time to eliminate the carboxyhemoglobin in the patient's system. So what does hyperbarics do? Is it that it's lowering that faster? Is it fixing the acute neurologic issues? Or is there some other role?
The whole premise of hyperbaric oxygenation is to prevent / at least reduce the probability of delayed neurologic sequelae. A lot of these patients eventually, whether it's months or even years later on, might go on to Parkinsonism, altered mental status, amnestic syndromes. And there's a decent amount of evidence showing that hyperbarics can at least reduce the probability of such syndromes. And with that in mind, you want to give your patient the best probability of success.
Let's say I have a patient who comes in with altered mental status, or they have some other severe manifestation. It takes a while to figure out exactly what's going on. I get the coax level back. Let's say it's 28, but I've had the patient on 100% non-rebreather now for a couple of hours, and they're improving. They may even be asymptomatic at the point in time where I get my coax level back, that initial co-oximetry level. Do I still need to consider transferring this patient for hyper? I'm going to get a tox consult. I'm still calling the poison center. I'm going to get a consultant on the phone. But what would the recommendation here be? My patient is normal in front of me, but they had a very high level. They had severe symptoms. Should I be transferring that patient for hyperbarics?
You know, the level was high 20s. My question for you is, what do you think the level was in the field?
Good
right?
point. It's probably in the 30s or higher.
Yeah, exactly. Right. Assuming your ED doesn't have carboxyhemoglobin just hanging around, you need to remember that concentrations or levels will naturally go down with time. That shouldn't reassure the clinician, which means if you have a scary level, consult your local poison control center, because especially in the context of neurologic disturbance, they're at least going to want to consider hyperbaric oxygenation.
Are there any hard and fast rules where you say, I don't care what the level is for this patient, they've got an exposure, I want hyperbarics on them?
If you don't have any other reason for neurologic disturbance, you gotta call. A super high level, you gotta call. Keep in mind, there's always going to be a huge differential with emergency medicine patients. But if you only have carboxyhemoglobin as your answer, I think you got to call tox.
The other place that I've always been taught is in the pregnant patient with any significant level. Just go ahead and call, get them involved. It doesn't mean they're going to definitely go for hyperbarics. In fact, I've had cases where we transferred them to the center with hyperbarics, and then the person on the other end said, you know what, I don't think we need to dive this person. We're not going to pursue hyperbarics. But we have such a different threshold in that group because of the potential for fetal toxicity, even at lower levels. So the threshold for me to consult and transfer in the pregnant patient is extremely low, even if they don't have really serious symptoms. We have to take those patients even more seriously. Sanjay, before we finish up, let's wrap up with some big take-home points that everybody needs to go away with.
Carbon monoxide is a colorless, odorless, and tasteless gas that results from incomplete combustion of any carbon-containing product. Exposure often occurs unintentionally from the indoor use of gas-powered generators, camp stoves, or faulty home heaters. The symptoms of mild acute exposure are often nonspecific and can be confused with a viral syndrome in the context of the winter season. Most often, they'll present with headache, dizziness, nausea, vomiting, and generalized weakness. Influenza is often a common misdiagnosis. Significant exposures may present with altered mental status, myocardial ischemia, syncope, neurologic disturbance, or even cardiac arrest. Testing is done via co-oximetry, which determines the amount of carboxyhemoglobin. Treatment is guided by supplemental oxygen, which decreases the half-life of carboxyhemoglobin. And then lastly, hyperbaric oxygenation should be considered in patients with severe toxicity, i.e. syncope, altered mental status, myocardial ischemia, or neurologic disturbance. And as always, call your local toxicologist or regional poison control center to help determine the need for hyperbaric therapy.
All right, fantastic. That's all for the Core Content Podcast this week. We'll be back in 2 weeks on another cast. Until then, don't forget to pop on over the site, check out all the great posts from our faculty, and until next time, stay safe.